Okay, so the talk is pretty tight on time, so let's get to it. So I have no conflicts to disclose. So there are three things I was hoping to talk to you about today. There's arthrocentesis, lumbopuncture, and central venous catheters. It's modular, so if we're running out of time, we can skip the last part. So things to make sure we're on the same page about. So I will only be able to cover some aspects of the procedures. I can't go into detail about everything which is done. You will not leave this room knowing how to do this. The main purpose really is for me to talk to you about some new developments and my experience, I guess, and suggest some new directions in what may be happening going forward. And also a disclosure that the clinical vignettes are composites of several real clinical cases. They are not, in themselves quite real. So before we begin, as far as ultrasound goes for procedures, there are two ways of using this. There's ultrasound guided procedure, and here's one of our proceduralists putting a needle on the ultrasound guidance into a breast phantom. And you can see that it's a real-time technique. Ultrasound is used during the needle insertion, and you're watching the needle tip at all times, right? That's the definition of it. As opposed to ultrasound assisted, which really is a pre-marking technique where the scanning and the needle insertion is separated in time by however few minutes it may be. So you scan first, you mark, and then you put a needle in. Hopefully the patient has not moved in the meantime. So let's get started. So first one is arthrocentesis. So the real case, real age, 101-year-old man, actually had him last week on my service, lives in the community, is independent pretty much, and comes to the ER because for 2 weeks he had horrendous right leg pain and cannot ambulate. Has history of diastolic CHF, hypertension, gout, the usual gamut. In the ER, he gets a laundry list of radiology studies. He gets a hip X-ray, shows some osteoarthritis, but nothing spectacular. Knee X-ray shows also osteoarthritis and a joint effusion. Ankle X-ray is read as possibly a fracture, and they recommend a CT scan. He gets a CT scan, which doesn't show a fracture. He gets a low extremity venous duplex, which is also negative. He's admitted to medicine because he cannot walk. This should be familiar, I imagine. Okay, so physical therapy sees the patient pretty early in the emergency room, actually, and says that they can't do anything for him. He cannot participate because he is in tremendous amount of pain. So the next morning, the medicine team and myself sees him. The patient is somnolent, not engaging, kind of spaced out, has pinpoint pupils. We all know what happened to him. He's protecting his airway, has stable vital signs, and labs show a little bit of a creatinine bump, which at his age is pretty significant. He clearly has not eaten or drank anything since he's been in the hospital. On exam, he appears a little bit dry. There is definitely no edema anywhere, no signs of CHF. He has a very obvious right knee effusion with minimal inflammation around it, and is afebrile, and his white count is completely normal. Of course, we stop all his narcotics, and we ultrasound his knee. So here's a generic, not his knee, which is swollen. Don't need to know much about this. And here's an ultrasound of the knee, not his, but a similar kind of case. So you cannot put the probe on in various places. This is just the biggest pocket that we could get. I prefer doing arthrocentesis on the medial side, or it really depends on the patient position, and I'm right-handed, so that always factors in as well. Okay, so, and here's a hip ultrasound. So synovial fluid here is shown. It's a tiny amount. This is nothing to drain there. The ultrasound for hip effusion is, the ultrasound probe is lined up with the neck of the femur, as you can see there. So 4 hours later, person is again fully alert, complaining of a lot of pain, and we perform 2 procedures. We get arthrocentesis on the ultrasound. We get 60 cc's of fluid. We inject him with dipomedrol with lidocaine, and we also perform hip arthrocentesis. There is no fluid to drain, but we injected it as well. So this is real-time ultrasound guided cannulation. Needle is going into the knee effusion. We did not do it guided on our person, but that's what it would look like. And this is the arthrocentesis of the hip. People somehow generally are afraid of injecting hips, but I think it's actually easier than any other procedure, including the knee. So the arrow here shows the direction of the needle. You should aim for the neck right there between the femoral head and the neck. And here's a example of the needle going in. It's kind of faint. I couldn't get a better example in our collection of this, but this is from some other people of the web. And you're going to see a fantastic needle going in, right? It doesn't really take a lot of training to see that. And there is a flush of steroid being injected right there. Okay. So immediately after the procedure, the patient reports feeling fantastic. Of course, this is lidocaine, which is going to wear off. And next morning, he still feels great, probably because we drained all this fluid, because anti-inflammatory effect can take longer, of steroids can take longer than this. He now is able to walk 200 feet during his physical therapy session, and he is well enough to actually go home with home physical therapy. So synovial fluid analysis shows crystals of calcium pyrophosphate, so not gout, pseudogout. So arthrocentesis, right? So I think we don't do enough in the hospital, but how safe is it? So it is so safe, in fact, that the guidelines say don't stop anticoagulation, right? So, well, this guideline specifically is from cardiologists. What do they know, right? So there are actual studies done. So this is a very small study, but it's the only prospective cohort, as far as I know, only 100 patients. They had 3 groups. Group 1 was on DOAC, and group 3 was on nothing. Vitamin K antagonist was really nothing to talk about there. So there was 0 bleeds in the group 1, 0 bleeds in the group 2, and 0 bleeds in the group 3. So, small study, but kind of encouraging. So this is the study which everyone quotes. This is from a single center Mayo Clinic. There was over 7 years. They had over 1,000 consecutive procedures done on 480 people, and only half of them were guided with anything. So, and in the cohort, there were no events. There was some bruising, small amount of bruising at the site of injection, but there was no significant bleeding. So what are the indications for inpatient arthrocentesis? So I'm a hospitalist, and obviously there are non-controversial indications. The suspicion for septic arthritis is an emergency in the native not replaced joint, and diagnostic evaluation of a new joint effusion. Of course, we all know that these are indications. So, but I would propose, I would put it to you that we probably don't do enough of the following. So the standard approach is, it's not an emergency, you're fine, just go see your patient doctor. So the case I just showed you, I think, had a real impact, the joint injection in this patient. And I think we don't do enough of this. Why? Internists are no longer comfortable with a lot of procedures, and subspecialties are certainly very, very busy. Ortho, rheumatology, they're just too busy to inject all people with chronic pain. So another scenario, which I see with some regularity, is admission for a GI bleed. And we take care of the GI bleed and people ready to go home. And then you realize that the NSAIDs, which caused the GI bleed, they were taking because they're in excruciating pain. So you fix the GI bleed, you did not treat the proximal cause, so which a lot of times is a good thing to do. So this is kind of, I want to, like, this is sort of outpatient, inpatient merge. I feel like, I think we need to do more of these because they make a real difference. A deep breath. So the next one is lumbar puncture. I used to do them in clinic. So it kind of spans the inpatient and outpatient world for rule out neurosyphilis, of course, not for meningitis. So case 2, 42-year-old man with morbid obesity is brought in by New York Police Department because he was walking around the city barefoot and was agitated. no known psychiatric history. He's confused, combative, paranoid, incoherent. He's afebrile, and his labs are entirely unimpressive. So there is very little concern for meningitis or encephalitis, at least infectious, but still the LP is the decision was made to get an LP. So he gets medicated so he can tolerate the procedure. The landmark-based LP, which everyone knows, is attempted, and he has 12 passes of the needle in the emergency room. They cannot get the fluid. Reality is the patient cannot be properly positioned because of his body habitus. So the question now is, what do you do? Is there a role for ultrasound, and how do you handle this? So as far as ultrasound for LP is concerned, there are a couple of nuances here. So there are two different approaches you can use for needle insertion. There's a midline approach, which most of us know. And this is insertion of the needle in between the spinous processes in the midline. There is also a paramedian approach, paramedian oblique, and this paramedian approach can be done with ultrasound assistance or with ultrasound guidance. Again, assistance is just marking the spine. Guidance is watching the needle go in. You cannot do midline with ultrasound guidance because you cannot see the space, as I will show you in a second. So here's a beautiful diagram I borrowed from Dr. Salami. This shows what everyone knows in this room, probably. So this is somehow the only technique that we've been taught for years. So I did not know about the other one until very, very recently. I don't know why this is the only thing we're taught, but that is the one I was taught as well. So standard approach, in between the spinous processes, the needle is inserted, and that is it. Now, anesthesia, we practice in silos, right? We don't communicate with other specialties. We have no idea what developments are. So anesthesia has been using paramedian approach for decades, with guidance, without guidance. They also use midline approach, but paramedian they've used, again, for a very long time. So here, instead of going in between the spinous processes, the needle goes from a side a little bit and slides over the lamina. And this has certain advantages, at least theoretically. So very brief description of how you mark the spine for the midline approach. So you start with the probe in transverse, you mark the spine, you center on the spinous process in the left low corner. Right there is the spinous process, right in here. This is the spinous process. You center it on the ultrasound machine screen, and you mark the middle of the probe. So this is your midline. After that, you turn the probe 90 degrees, and now you align the probe with the long axis of the spine, and you slide it a little bit just so that the space you theoretically going to put a needle in is right in the middle of your view. So these eyebrows right here are the two spinous processes now in the longitudinal view right here, as is shown over here. And when you do that, you put another marking on the skin. And once again, ultrasound assisted is just a fancy word for skin marking. And the steps here are you do it in transverse, then you do it in the longitudinal, you get a cross with the target, then you complete that cross. And then I usually do several levels. I actually do 2 or 3, just so I know what the best space is, okay? So median approach, for some reason, like I said, historically preferred by internal medicine. Problem is spinal canal is not visualized. The depth of a needle insertion cannot be estimated because of this, and you cannot really do it under ultrasound guidance because you cannot possibly see where the needle is going. The other problem is that, yes, you can see someone who doesn't have a space at all, but there are a lot of patients with difficult anatomy, which you will not be able to identify with midline approach. So paramedian oblique. So how do you do this? So you start in the midline, longitudinally, you're aligned with the spinous processes, then you slide to one side and you get a picture of the lamina, these waves right here, a lamina on the ultrasound. And then you just turn the probe a little bit towards the midline, like so. And what you end up seeing looks like this. So in between the two lamina, superficially, you see ligamentum flavum, but deep to it, you see what's called a posterior complex. The most important part of it is dura, and deep to that is going to be the spinal canal. So you directly see the path your needle should be taking, and you can actually measure how deep your needle needs to go. This was validated, and because lidocaine is injected, obviously, before you put the needle in, the actual needle insertion is off by about 5 millimeters compared to what you've estimated here. So here's a real patient of mine where both the midline and paramedian oblique markings were made. So this is the midline of the spinous processes. These are intraspinous spaces between the processes where you could theoretically put the needle. This is the lamina level, which is sort of in between the spaces you would insert the needle in the midline. And this spot right here is where you would do the paramedian LP. Now, the other thing is that you can do this technique under direct visualization. I usually do it just by marking. And what you do is you know the angle that your probe made with the skin. So you know at what angle to insert the needle. So here the angle happens to be pretty steep, but that is the angle that you need to take to get to the fluid. Okay, so what is the actual evidence, right? So anecdotally, I can tell you that since I adopted this technique, I believe that my success rate has gone up with LPs. But, what is the data? The problem with the data is that there is virtually no literature on actual lumbar punctures. All the literature is from anesthesia. It's pretty good quality data, but there is a tremendous difference between someone who does, say, 20 procedures a year or 50 procedures a year and someone who does them every day, right? So the extrapolation of this data needs to be done with some caution. So anyway, in 2024, this year, there are 2 quality meta-analyses published. This is one of them, 71 studies, and they compared LPs by procedures by landmarks versus use of ultrasound. These were both guided in the markings, and both midline and paramedians were included. They analyzed them separately. So what transpired here is it seems that ultrasound assisted, which is the second line there, the success rate, it was clear from the meta-analysis that that there seems to be a benefit. Apologies. So it's the first group of studies right there. So there seems to be a benefit in favor of using ultrasound. The problem is there was pretty tremendous heterogeneity in the studies, and that's why the authors called the quality of data moderate. Interestingly, in Bayesian analysis, you can and should assess the amount of information which is available, and they determine that the correct number of studies it's reached the threshold for the significant amount of information. So these answers are valid, right? So still there's heterogeneity. They did not do meta-regression, so we don't know what is associated with success and what is not. And this was not the same for real-time guidance. There was significantly less certainty in what there was still benefit in the meta-analysis, but there was a significantly less certainty. Second meta-analysis, they somehow included 3 more studies than the previous one. Again, included both midline and paramedian, and it seems like results are pretty consistent. That there is a benefit. They called this level of evidence moderate for both. What I like most about this is that they did some subgroup analysis. Again, I wish they did meta-regression, but they did subgroup analysis, and the high-risk patients, which are pregnant women and obese patients who you cannot bend, clearly there was a benefit. And but interestingly, in the subgroup of patients who were judged to have easy anatomy before the procedure, there was still a benefit to use of ultrasound, which I thought was pretty interesting. Okay, so there was also a meta-analysis published very recently on the comparison between midline and paramedian. And from this, paramedian came on top. But in this case, there was really very little confidence in what they arrived at because there is not enough studies. There was significant risk of bias, and there was very significant heterogeneity. So they did some important subgroup analysis. Again, there was no meta-regression, and it turns out that in subgroup of OB patients, there was no heterogeneity and significant benefit, which I think is important. In non-OB patients, heterogeneity remained, and they couldn't figure out why. And when they limited the analysis to low risk of bias, again, there was no heterogeneity. So that aside, what I think is, I can't prove it to you, but I think that these effects in obese patients and pregnant patients are related to the fact that you cannot position them appropriately, in quotes. You cannot bend their trunk. And turns out that you may not necessarily need to do this for the paramedian LP. So this was a single center RCT, unfortunately only 50 patients, single operator, so the quality of the study was obviously suspect right there, but patients were randomized to midline or paramedian without any ultrasound, and they were allowed 2 attempts without bending the person before they had to take some heroic measures to bend the trunk. So they also didn't report how many patients there were in each group. So in midline approach, there was 17 failures, and there was only 1 in paramedian. So this jives with my experience. I don't think you need to bend patients if you going paramedian, and I think that is going to be a big advance. I invite everyone to think about this and consider. The space is much larger. I think the success rate is higher, and that's it. So the summary of LP data: ultrasound likely improves success rate versus landmark per patient. There's no robust evidence that paramedian is universally superior to midline, but there is a suggestion that it may be so in OB patients, in the obese patients, and in the elderly. This possibly is explained by the wider space in the paramedian approach, and trunk flexion may not be needed. So there's also some reports of decreased rate of back pain and post-LP headache, which I think is important, but this is definitely not conclusive. There's very weak data about ultrasound guidance. So as far as I'm concerned today, the biggest bang for the buck is with ultrasound assisted. So basically pre-mark the spine and go forward. Yep, and like I said, LP data is limited. Most of what we know is from anesthesia literature. So no talk on LP is complete without this one very nifty study. Very briefly, so this was a multi-center study which randomized about 7,000 patients. And what they did was they looked to see whether there is a difference in success rate for right-handed and left-handed operators, depending on how the patient is positioned. So it turns out that you are better off if you're right-handed to have the patient's head on your left, so that your hand points towards the head when you insert the needle. And if you're left-handed, you should put the patient in the opposite direction. So this is extremely simple, and I think this is a great study. I, again, suggest that you guys try this. Okay, so I mean, very anticlimactic conclusion to this. So we were able to get this on the first stick because he had, despite his body habitus, had very well identifiable landmarks, and we just had to use a long LP needle. The rest was unremarkable. It was in the end attributed to alcohol use. Another deep breath. How are we doing on time? Yeah, sir.
Likely to tap into any nerves?
No, so you're less likely to get into the nerve space, and you're less likely to get into vascular space with paramedian. There is a lot of data about this. So the data comes from catheter insertions. Catheters, when you go midline, can go in any whichever direction. Paramedian, there is a lot of space between the puncture site and the nerves and the vessels, apparently. Sir?
The current median approach affect the opening pressure at all?
No, so I don't think so. So all you need to do is if you're connecting the tubing, right? So the bottom of the manometer needs to be at the level that you want, right? Which is the midline of the spine. So that should not affect anything. As a matter of fact, next time you do an LP midline and you have the patient in fetal position, try to unbend them, and you will see that a lot of times the pressure goes down, because when you bear down, the CSF pressure can go up, and you can get falsely elevated CSF pressures with this. So the less you bend the patient, theoretically, the better, right? So that's another reason why I like this approach. It can be done sitting up as well. Obviously, in the hospital, I almost never do sit-up procedures sitting up. Anything else? Okay, so the next one is most fun for me, but a little too technical and detailed, but you can interrupt me anytime you want. So before I give you a clinical vignette, I need to tell you how we do this, because this is different from most of the places, as far as I know. So in my shop, all non-emergent central venous catheters are placed with at least 2 people in the room. One of them is an operator, and the other one is a sonographer. I don't mean sonographer, professional sonographer, but someone who knows POCUS and can assist with this. EKG monitoring is absolutely required, whether you're on the floor or anywhere else. And we use modified Celgene technique, meaning we insert the angiocath, and then the guide wire goes through the angiocath and not the stiff needle. Once venous access is gained, insertion of the guide wire is performed with EKG monitoring and with real-time cardiac ultrasound, and we watch the wire go into the heart. Visualization of guide wire within the RV array or distal vena cava is required prior to vessel dilation. If we don't see that, we do not dilate the vessel, because we need to figure out if we're in the correct spot. We call this combination of spots, we call it central venous system, for better or for worse. So that's for the purposes of this talk. Okay, so the logic behind this is this. So one of the biggest problems with central line insertions is malposition. So malposition can be extravascular when the catheter ends up being in the mediastinum or soft tissue or what have you. It can be arterial, or it can be venous, meaning it is venous, but it's in the wrong vein. Okay, so venous are by far the most common ones. The issue is that it's not enough to see where your needle entered, because the access to the wrong compartment can be not at the venous puncture site. It could be distal. Sometimes the needle or a wire can first go into a vein and then enter an artery, or a wire can go into the soft tissue through the vein wall. So it's not enough to look at the entry site. So, and importantly, guide wire won't be within the central venous system with any malposition. Okay, so you will not see it on cardiac ultrasound if the patient has views. And I will show you some examples of this. So once again, this is our logic. We do not dilate unless we see the wire. If ectopy is seen, the wire is likely in the right ventricle. Unfortunately, sometimes the wire is in the right ventricle and there's still no ectopy. So this doesn't, save you from this possibility. Guide wire within the central venous system basically rules out any malposition. So that is the key to our approach here. And a flush test, which is a agitated saline rapidly injected intravenously, does not rule out venous malposition. This is very important. So some people use timing to count how many seconds it took to see the flush in the right side of the heart, but this is highly unreliable. They're both false positives and false negatives. Okay. So what do we do? EKG, as I told you, then there's some ideal cardiac views, and those are the ones which visualize IVC, SVC, and RA all in the same view. And there are 2 of them. There's subcostal bicaval view and peristernal long axis RV inflow view, which I will show you in a second. Alternatively, if you cannot get either of these, you can visualize right atrium separately, but then you also need to see the IVC separately. RV can be visualized from any one of these 3 views. Sorry, RA. And IVC can be either the standard thing they do in cardiology, which is subcostal, or you can go from the liver side, which is what radiology would do if you ask them to rule out IVC clot. Okay, EKG monitoring. On the floor, there are a couple of possibilities. So obviously, patients can be on a monitor. Some ultrasound machines have EKG capabilities. But if you don't have either of this, you can just hook up a patient to a floor EKG machine. All you need is limb leads. Okay, ideal views. So this is the so-called subcostal bicaval view. And it's called so because there are two vena cava there. So there is IVC, SVC, and RA is in the middle. LA is not a constant feature, but is frequently seen there. Importantly, you may see part of the tricuspid valve, but you don't have to, and it's really not reliable. So that should not be counted on. I think it's a fantastic view. Anyone who's gotten a regular IVC view with some training can get this very rapidly. So all you do is you turn the probe a little bit to 11 o'clock, and then you can fan it a little bit towards the patient's right shoulder. So this is another picture of the same with the cut plane. And here's an example of dialysis catheter, which goes through the SVC, and you can see this catheter in the array right there. This is not a guide wire, but from my experience, visualization is very similar for catheters and lines. Here's an example of a guide wire going from the SVC, do you guys see it? Right, into the array, and then it turns towards the tricuspid valve and gets lost there. Probably goes into the right ventricle, but you can't really visualize this. So this was actually studied, a relatively recent study from 2022, fantastic operating characteristics of this view when compared to TEE for catheter tip position. It was not for guide wires. Okay, so peristernal long axis RV inflow view. So this is a standard echo view, but not taught in beginner's POCUS, taught in the advanced POCUS. Everyone knows there is RV in the array. This is an example of someone with chronic RV failure. But I included it because everything is so prominent and well seen. It's relatively few people who realize that there are two vena cavas in this view as well, which is pretty handy. So the way to obtain this view is you start with peristernal long, those who know how to do this, and then you just tilt the probe, fan the probe, whatever your terminology is, towards the patient's right hip. And here's an example of a wire going through the SVC into the array and then crossing the tricuspid valve. Tricuspid valve is routinely visualized in this view, of course, because there's array and the RV. Okay, you guys see the wire, and then the wire is pulled in the end of the, right, you see it? In the end of the clip, the wire is being pulled up. We're going to see this in a few examples. So here's a dialysis catheter, which went from the SVC through the array into the IVC. Okay, so, but because it's not, in the same plane, you cannot see the beginning of the catheter, you just see the portion where it enters the IVC. I think is pretty nifty. Okay, so if you cannot get a good view where everything is included, you can get array separately and IVC separately. So here's a subcostal 4 standard view, and you see the wire right there in the right atrium. You guys see the dot? Yeah, so this is a wire. This is an echo view called peristernal short axis view. It's at the level of aortic valve, the Mercedes sign in the middle. But there are some useful things here. There's RV in the middle, tricuspid valve is on your left, and pulmonic valve is on your right. Array is below the tricuspid valve. And here's an example of a wire being seen right there, and it's probably going through the tricuspid valve as well. What extends down into the LA is an artifact, right? So there is no wire in the left atrium. All right. So this is subcostal IVC, and again, this is an upper body catheter being inserted. So the wire went through the SVC to the right atrium into the IVC, which is a very common occurrence, and it's here being pulled up. So you can see this. So this is a subcostal view. So this is one of my most favorites. So this wire went through the IVC and entered the hepatic vein. accidentally. We were not trying to do a liver biopsy here. So, and it's being pulled, as you can see, right? And that happened 3 times on my memory. This is a cool view. This is a view from the side of the IVC. And again, what you see is the catheter, the wire is entering the inferior vena cava. And now the wire is being pulled up. But once you see this, you know you're in the correct spot. Okay, so now a case. 53-year-old woman with end-stage renal disease, as one has it. Multiple access issues in the past, requires a temporary dialysis catheter because she has another bloodstream infection and her dialysis catheter was removed. She has stenotic right IJ on ultrasound and clearly not a good target for cannulation. So patient was absolutely adamant about not having a groin access. And so we selected the left IJ. The patient had very good cardiac windows. Left IJ was cannulated successfully. The guide wire was successfully advanced, no resistance. No activity was seen on EKG, but the wire was not visualized on cardiac ultrasound. So we withdrew the wire. And the first question that we have in our mind is, did we accidentally somehow enter the arterial circulation? So the way to sort this out, at least that's what we do, is we do a flush test. Boom. So you see here that echo contrast hits the right side of the heart. So you know you're injecting it intravenously. If you were in the artery, you would not be able to see this, okay, at all. Okay, so that was reassuring. So we refloated the guide wire and again, could not see the guide wire in the heart. So what does this mean? Here's a kicker. So the next thing I asked my helper to do is to look at the peristernal long axis view and see what coronary sinus looks like. I will explain in 1 second. So on the left is a peristernal long axis view of someone with gigantic coronary sinus. And on the right is someone with a normal coronary sinus. Okay, see the difference? So this is essentially a pathognomonic finding of the following. So this is how our circulatory system looks like. The superior vena cava in us adults, in most cases, is on the right. But when we're embryos, we start with 2 superior vena cava, and in some people, it doesn't regress. So that's called persistent left SVC, and this configuration right there is seen in 90% of those cases, and they have 2 superior vena cava. So in majority of us, it regresses, like I said. So in embryo, the left vena cava drains through the coronary sinus into the heart. In an adult in whom the left SVC regressed, the only thing which drains into the coronary sinus is the myocardium. So the coronary sinus usually is small because it doesn't have a lot of flow. If the left-sided SVC persists, the flow is tremendously higher and and the coronary sinus is going to be tremendously dilated. Somewhat dilated coronary sinus can be seen in heart failure, but when it is gigantic, like I showed you, this is almost always, virtually always, a left-sided SVC. So if you put a line in someone with the left-sided SVC on the left side, there's a good chance that it's going to go into coronary sinus. And if it does, you're not going to see the tip in the heart. It is theoretically possible to guide it into the correct SVC in most people, but not with ultrasound, with fluoroscopy. And if you're putting a line on the right side, usually it goes into the correct spot, though it can cross over sometimes and be on the left side in the coronary sinus as well. About 10% of people, the wrong SVC regresses. So they end up with just left-sided SVC. So here's an example from the literature. This person has 2 central venous catheters in the wrong place. So this is one of them. This is in the left-sided SVC. And then that wasn't enough. He received the second one, which crossed over and also ends up in the left SVC. So some controversy about whether this is safe or not, because there is not enough patients with this. I would try not to infuse anything caustic into the coronary sinus, but you know, who knows? Anyway, so we thought that left SVC was unlikely because of the coronary sinus, and we thought we just ended up in the wrong vein. So proceduralists know that there are a lot of these little veins which are tributaries to the large veins we all know about. Fortunately, and catheter can end up in any one of them. Fortunately, it's very rare. The two most common ones is the internal thoracic, internal mammary, and the azygos. And they are much more common with catheters inserted on the left side. So here's our patient, and you can see the dialysis catheter tip because we did insert a dialysis catheter. I will tell you later. And it is in the azygos vein right there. So azygos vein goes posteriorly, as you see it in this diagram. It is in green. And the internal mammary goes anterior. This is a great CT right here. So in the diagram, the blue one is the azygos vein, and internal mammary is in green, goes anteriorly right there. Okay, so this is what happened in our patient. In some people, orientation of the takeoff of the azygos is such that there is a direct passage from the right brachiocephalic. The wire very frequently hits the ostium of the, here it's drawn, on the wrong side, but it's directly in the path of the line. So chest x-ray confirmed HD catheter was in the azygos vein. The catheter drew and flushed both ports, and patient had no pain. So she actually had 2 dialysis sessions successfully through that thing. And because we were in a bind, this was done in consultation with her primary team, we decided to proceed. So I looked at all our central lines, and the current database has something like 318 of them, not very many. Absolute majority, because we put basically all temporary dialysis catheters in the hospital right now, and rarely other things. So absolute majority of our lines are right-sided and are right IJ. There were 4 cases of venous malposition, and all of them were left-sided. Okay, so probably 10% of these are left-sided catheters. 2 of them went into the azygos from the left side. 1 is a very rare thing. It went in the intercostal vein. And 1 gave what we call a necklace. It went from the left IJ into the right IJ, right, across the midline. And in all of these cases, the guide wire was not visualized, and we pretty much knew that we were in the wrong place. But in consultation with the referring teams, the decision was made to place the catheter because the need was dire. So conclusions for what I wanted to tell you about the central venous catheter. I'm hoping that we're in the beginning of the movement where POCUS may be able to definitively decide whether there is or is not a correct placement of a catheter. And I am hoping, again, that chest x-rays as a routine going to go the way of the dinosaurs. Of course, if you suspect something is wrong, you need an x-ray, but doing them routinely, I think, makes no sense, increases cost, and delays the use of the catheters that we insert. So to summarize everything that we talked about today, I was trying to promote 3 kind of ideas here for you. So first, I think that musculoskeletal injections may be underutilized in inpatients, particularly in the elderly. Arthrocentesis is an incredibly safe procedure. There is good evidence that ultrasound improves success of lumbar puncture, however you use it. Paramedian LP may be associated with higher success rate than midline, but quality of the data is not there yet. Paramedian LP may allow for the procedure without truncal flexure, which I think is going to be very important. Ultrasound guided technique may not be superior to ultrasound assisted for lumbar puncture. So doing it in real time takes much more training and may not be worth it. For central lines, I'm hoping that one day x-rays are not going to be routinely done. And that is all I have for you.